Dr. Professor K.S. Gopinath. A warm welcome to you all, sir. Dr. Lorenzo Cohen, Professor and Director of the Integrative Medicine Program, University of Texas, MD Anderson Cancer Center, USA. Dr. Lorenzo Cohen is the Richard E. Hines Distinguished Professor in Clinical Cancer Prevention and Director of the Integrative Medicine Program at the University of Texas, MD Anderson Cancer Center, Houston, and Distinguished Clinical Professor, Fudan University Cancer Hospital, Shanghai, China. Dr. Cohen is passionate about educating others on how to prevent cancer and maintain optimal health across the lifespan. Dr. Cohen leads a team conducting NIH-funded research and delivering clinical care of integrative medicine practices such as meditation, yoga, Tai Chi, massage, diet, exercise, acupuncture, and other strategies such as stress management, music therapy, emotional writing, and more aimed at reducing the negative aspects of cancer treatment and improving quality of life and clinical outcomes. I would like Dr. Lorenzo Cohen to come and give the opening remarks and take over the session.
Thank you. Thank you all for joining us for this session in oncology. I think you heard from this morning how important lifestyle is in a number of non-communicable diseases, but I think cancer, the evidence is as high as it is for diabetes, as well as heart disease, stroke, respiratory diseases, etc. Cancer affects 50% of the world, if not more. 1 in 2 men and 1 in 3 women will be diagnosed with cancer in their lifetime, and the incidence of cancer is increasing precipitously. And the saddest thing is that, like the other non-communicable diseases, the majority of cancers are actually preventable. The majorities of cancers are not inherited. So today we're going to be focusing on some of these factors with these 3 eminent speakers. The first speaker is Dr. Rajesh K. Grover. Dr. Grover is the CEO of the Delhi State Cancer Institute and has been in that position for 9 years. This institution has always had, when I first met Dr. Grover, when he took over this position, at the core an interest in integrative medicine. Dr. Grover, when I first met him, was clearly passionate about Ayurvedic medicine, other forms of healing, and in particular, yoga. And when they built their first center in New Delhi, had an area that was specifically focused on the incorporation of yoga as a therapy for cancer. He's a clinical oncologist, has been practicing in the field for over 30 years at reputed medical institutions across the country, and has also traveled far and wide around the world looking at the incorporation of new technologies to bring them to India, as well, of course, as bringing up the old technologies of Ayurveda, yoga, and etc. Join me in welcoming Dr. Grover.
A very good afternoon to everybody. Thank you very much, Professor Cohen, for your very lucid introduction. And I also thank the organizer for giving me the opportunity to be presenting to you an important topic today, which has a lot of bearing what we plan and what we shall do in the future. But I have a very risky task of opening the session soon after the lunch break, and it will be difficult for me to keep you awake. I think some of the people already gone off to sleep and they have not reported for the session. But whosoever are there, I'll try my best, because incidentally most of my talk is related to incidence in data. Because what we are showing is sort of lifestyle and differential demographic distribution. So that differential demographic distribution will have a lot of data, you'll have to bear with me, but that also will make you understand what we are doing or what we want to do in the future, not only to diagnose early but even to prevent cancers. And you must have heard from the very wonderful talks since morning, especially from Dr. Nagendra, Dr. Hegde, and Dr. Satbir, how we can prevent lot many cancer by changing a lifestyle or by adding yoga or meditation or Ayurveda, by preventing good health. So that is what our aim has been. And with this aim in back of the mind, I'll try to do justice to role of lifestyle in the differential demographic distribution of cancer. I bring warm greetings from Delhi State Cancer Institute, which is in Delhi. We have two centers, East and West. Now, once we talk of role of lifestyle in differential demographic distribution, first I like to pose these questions for you and then try to come to the answers. That is there a differential demographic distribution of cancer? If yes, then the type of differential distribution, it just in the incidence or it just also in the type of cancer or both? Then if yes, then what are the reasons thereof? What is the role of lifestyle and other factors? Suggestions to minimize the incidence globally to make cancer a history, that should be a long-term goal. Now, to understand that demographic data better, WHO has divided the whole globe into 21 different sectors which have nearly matching socioeconomic or demographic profile of the population. On the basis of that, they have given this distribution where number one is Eastern Africa, then Middle Africa, then we have Northern Africa, then Southern Africa, and then Western Africa, and then we come on to others like this is Caribbean, North America, Central America, South America, and then others, such 21 centers. On the basis of this, we try to distribute how cases are being distributed in these regions. And what we can see from this slide is a little busy slide, but still I like to request you to focus on the main difference, how the incidence is varying, right from almost 88 from Middle Africa, 88 per 100,000 population per year, that is the incidence what now we define as, to almost more than 350 in Australia and New Zealand, and in between then we have Western Europe. This is, I have put them in descending order, and we can see how the incidence is varying both in male as well as female. The average is also over there. So there is a wide variation. We in South Central Asia, where India is included as, we are almost third from below. Now I do not know whether in these nations the incidence is being reported as so low. Is it because of underreporting? Or it is actually so low? Or it is because of lesser longevity? The incidence is also coming low because of low longevity. So this is a matter of further study. But what is important that the variation is there a lot. Now, what are the reasons for those variations? This will come to later. And this is how we are trying to divide site-wise. Again, divide in two groups, more developed countries in the middle and less developed country on the right side of your slide. And here we've seen that developed countries, prostate comes as number one, followed by lung, colorectal, stomach, and bladder. Well, in developing countries, again, although the lung is still number one, but next is liver cancer, which is next is stomach cancer, number two. Third is liver cancer. Fourth is colorectal, and prostate comes at fifth number. So this is because of that difference in lifestyle and other factors related to the nutrition and infections, that this variation is there. Another thing which you can see, the overall incidence, still when we talk of age standardized rate, this is age standardized rate for population between 0 to 74. So they are comparatively become comparable. So here we have all cancers almost 300 per 100,000 per year. In less developed is 160 per 100,000 per year. And the cumulative risk is 30.1 over in the developed countries, all cancers, and 17. So there is a significant difference in the overall incidence rate in the developed countries between and the developing countries. And similarly, in the females, then breast remains number one in both the groups of countries, developing as well as developed. But see the difference in the incidence rate of ASR is 66.4 in developed countries and 27.3 in the developing countries. Significant difference. But again, the next number two comes is cervix uteri, which is at number 8 in developed countries, but it is number 2 in the developed countries. So differences are there. And this is giving the busy slide, but what we are trying to show the absolute number, how many cases are there, but we have shown that in percentage. And here I like you to focus again when you're talking of USA, Europe, Australia, New Zealand, and Southeast Asia. We can say the overall prostate remains number one in USA, while in Europe, overall is the both sexes combined, so breast is more than prostate. Well, in Australia, New Zealand, prostate is one, but what like to focus upon you is that lung is number 5 in Australia and New Zealand, compared to either number 1 or number 2 in USA or Europe or in Southeast Asia, but here is number 5. Again in Southeast Asia, the breast forms number 1, cervical cancer forms number 2. This we see the same thing in males. Again, prostate remains number 1, followed by lung. Same in Europe, prostate number 1 and lung number 2. In Japan is the stomach which is number 1, followed by colorectal and then lung. So it's very unusual present in Japan where stomach cancer is number 1 as a leading cancer site in males. And in Southeast Asia again the lung, colorectal and lip and oral cavity in that order. So the differences are there. This we are talking of the SAARC nation. In fact, we are organizing a workshop for SAARC nation in the next month and they are trying to compare the data. In Afghanistan again stomach becomes number 1 followed by esophagus, lung, lip and oral cavity. Now lip and oral cavity are coming up in high number in this group of the countries which will not see in the rest of the world. In Bangladesh is lung number 1, esophagus number 2, pharynx and then lip and oral cavity. Bhutan again stomach, esophagus, lung, liver, and in India is a lung number 1 overall in males, followed by lip, oral cavity, stomach and colorectum and other pharynx. This Maldives again the lip and oral cavity is number 1. Nepal lung is number 1, while in in Pakistan, lip and oral cavity, lung and non-Hodgkin's lymphoma, which is again unusually very high, otherwise is not that common in the developing countries. More seen in developed countries, especially in elderly age group population. But there are gross variation, like in Sri Lanka again, lip and oral cavity. This is because of the typical habit of chewing tobacco in this part of the world, that these kinds of cancers are more common. Again, when you say the lifestyle plays a lot of role in the demographic distribution of these cancers. In females, if you compare the same situation, breast uniformly remains number 1 in almost all the countries, whether it's in USA, Europe, Japan or Southeast Asia. But next then changes. In female in the US, it's lung is number 2, while in Europe is colorectum, which is number 2. Japan, it becomes colorectum again number 2 and stomach number 3, which was number 1 in males. In ladies also is fairly high at number 3rd level. But in Southeast Asia, what we see breast number 1 and cervix number 2 and colorectum coming at number 3. So variations are there. Similarly in Afghanistan, breast and cervix, Bangladesh, breast and cervix, Bhutan, cervix number 1 and stomach number 2, and India, breast and cervix. This again in my own lifetime I'm seeing that, say about 15-20 years back, cervix in India used to number 1 cancer, but now it's becoming number 2, breast is taking over far ahead of it. Similarly, when we talk of these SAARC nations, between the females in Maldives, Nepal, Pakistan and Sri Lanka, breast, cervix, breast, Pakistan, breast, cervix is much low because it is expected in Muslim population because of practical circumstances in the males. Cervical cancer incidence is generally low, and that's why we are seeing the cervix cancer is low down. They are the number 3 compared to breast and lip, and then we have ovary after that. In Sri Lanka, again, breast and cervix, they are number 1 and number 2, as we are seeing in most other countries. But as we see from this overview of the data, yes, there is a marked variation in overall demographic distribution of cancer in different regions of the world. Even within the same country, you will have marked variation, like we talk of in India. There is a difference in cancer incidence, the type of cancer between North India, South India and East India, like in Dibrugarh, Assam, in the far northeast, we see many head and neck cancer cases. Down south, stomach and cervix is more common, while in north we have breast is more common, and gallbladder is unusually very common in the northern part of the country. There is a marked variation distribution of same cancer in different regions of the world. We have seen that. We may now study some differential distribution of some of the major cancers individually and the reasons for the differences, what is the role of lifestyle. When we talk of global cancer strategy, lung cancer, we'll see Central and Eastern Europe, they have very high incidence, is 57 per 100,000 per year in males and 9.8 in females. What is little unusual that in Northern America, where female incidence is very high. Similarly, Northern Europe and Australia and New Zealand, although it is reduced now, but still it's fairly high. But the bottom we have is Middle Africa, with just in incidence just 2.8, and Western Africa 3.1, compared to 57 in the top where Central and Eastern Europe are there. And this is primarily because of change in the smoking pattern, smoking habits. So lung cancer is the most commonly diagnosed cancer of the world. Adult smoking prevalence about 20% Chinese females is becoming very high in Chinese females. The adult smoking more than 20%, and they have much higher incidence of lung cancer compared to the Western population, about 21.3 per 100,000, which is much higher than what we see in most of European countries and Germany and Italy, as I'm shown. Other factors which do contribute to the lung cancer incidence is unventilated coal-fueled stoves from cooking fumes in China, exposure to occupational and environmental carcinogens such as asbestos, arsenic, radon, and polycyclic aromatic hydrocarbons coming from the pollution. Difference in the type and quantity of tobacco consumption, which is making major difference in the incidence of lung cancer cases. Smoking accounts for 80% of the worldwide lung cancer burden in males and at least 50% burden in females. It used to be highest in North America and Australia, but as I mentioned, it has now come down, and the Europe is #1 in lung cancer cases. This is because of control in tobacco. Australia, they had very aggressive anti-tobacco campaign because lung cancer has become #5 in the Australian population now. So there have been a proven tobacco control in the intervention which have made a difference in the lung cancer incidence, which some of these are raising the price of cigarette and other tobacco-related products, banning smoking in public places, restriction of advertising of tobacco products, counter-advertising, and treating tobacco dependence. It has been reported that 10% increase in cigarette prices reduces cigarette consumption by 3 to 5%. Unfortunately, we still officially sell cigarettes at duty-free shops, which could be stopped. That means the government is officially sponsoring cigarette sale. But there is a strong commercial pressure which we as doctors must raise a voice against this, because this is one cancer which can be prevented to a large extent if tobacco can be controlled. Similarly, if we come to the breast cancer, we see that Western Europe is again #1, followed by Australia, New Zealand, Northern Europe. But what is important to be seen, then in Eastern Africa, the incidence is just about 19.3 per 100,000, compared in Western Europe, which is about 90 per 100,000. Another factor, although not a part of this presentation, but I like you to take a notice. This is on the right part of the slide is the mortality rate in this, which is nearly remaining the same almost. If you see in the different countries, although the incidence difference is more than 5 times, almost 5 times from 19 to 89, but the mortality rate are nearly remaining the same. This is because of the late presentation. In most of these countries which are low down, most of these countries are still developing countries, LMICs. The breast cancer incidence is low, but the stage at presentation is very advanced because the results are poor. So we all know most of these factors, reproductive and hormonal factors, with a long menstrual history, nulliparity, recent use of postmenopausal hormones, alcohol consumption also increase our risk of breast cancer. Then in prostate cancer, which is now worldwide becoming as the #1 cancer in all the developed countries, and overall is #2, but in developed countries coming as #1, and developing countries also catching up very fast. But because of other lifestyle-related factors, the lung and what is head and neck, they become more important in most of the developing countries. But again, that's why you are seeing the variation is gross, 104 per 100,000 in Australia, New Zealand, to just about 4 in South Central Asia. Now, whether this again I was mentioning is underreporting or lesser longevity, which is causing such a low incidence. But there is a gross variation, and factors could be age, chronic infections, or hormonal changes with time. Similarly, cervical cancer, we see there is very marked variation again, right from 4.5 per 100,000 at the bottom to about 35 per 100,000 in the Eastern Africa. And again, we see these are cervical cancer is generally considered to be a disease of low socioeconomic group, and that's why we're seeing the countries on top over here, the Eastern Africa, Western Africa, Southern Africa, South Central Asia, South America, Melanesia, while the most are developed countries like Western Asia, Australia, New Zealand, North America, they are at the bottom. In the other cancer, they were at the top. So this is what the demographic variation is there because of lifestyle factors. So cervical cancer, we all know India has the maximum number of population, and we know the factors which are there. Generally is early childbirth, poor sexual hygiene, human papillomavirus infection, poor nutrition, multiple pregnancies. So these are some of the factors which predispose a woman to high risk of cervical cancer, which we are seeing in all these LMICs, low middle income group countries. Colorectal, again, we are seeing the variations are there. But here, those countries which are developed, Australia, New Zealand, Western Europe, Southern Europe, Northern Europe, they are on the top, and lower income group countries, they are at the bottom. So this is just the reverse of what we have seen in the cervical cancer. But most of developing countries, they have the same kind of pattern. The top higher incidence is in the developed countries and lower incidence in the developing countries. The colorectal also falls in the same group, and this is again because the dietary factor which are relevant to a large extent in the incidence of cervical in the colorectal cancer, especially a low fiber diet, high consumption of meat, which is prevalent in this group of population, while
what we see in our country, the diet which we have, Indian diet is that way is one of the most protective diet as far as colorectal cancer is concerned. Now, because of this awareness, even in USA, people are becoming more aware to having a high fiber diet and switching on to vegetarian diet. And that's why the incidence in these countries is now started reducing. Otherwise, some of the patterns which are the obesity, increased prevalence of smoking. But these are all modifiable risk factors in colorectal cancer, which include the physical inactivity, overweight, and red and processed meat consumption and excessive alcohol consumption. These are all modifiable, and they are different in different parts of the world. And that's why there is a difference in the cancer presentation also in different parts of the world. When we come to stomach cancer, again we have Eastern Asia, which is number 1, Central and Eastern Europe number 2, and then on the bottom we have North Africa, South Africa, Australia, New Zealand falling in between. This is again because of the dietary habits over there, especially the refrigerated, salted food, decreased intake of fresh fruits and vegetables, H. pylori infection. These are some of the reasons because of which the stomach cancer incidence varies so much from in different parts of the world. Then lip and oral cavity, as I mentioned, is very unique to the East Asian region because of the oral consumption of tobacco as well as smoking, and in different forms. Even smoking also sometimes taken the reverse part, which is very prevalent in the down south part of India and Andhra Pradesh, which is called as chutta smoking. So these are some of the factors which are predisposing population, this region specifically, to submucous fibrosis, the precancer lesion, and many of them ultimately going on to causation of lip cancer. So these are some of the areas which is commonly found in Melanesia, South Central Asia, Central and Eastern Europe, and lowest in Africa, Central America, and Eastern Asia for both males and female. And as I mentioned, smoking and alcohol, they are some of the common factors. What we are seeing now, along with that, is a change in the sexual behavior. Human papillomavirus is being seen as one of the causative factors in oral cancer also, and that's why we are seeing some cases in the developed countries also which are rising because of the lip cancer. Similarly, nasopharyngeal, again, it's in the Southeast Asia, Southern Africa, and the developed countries the incidence is less, as we see in Western Europe, Northern Europe, and South America, Melanesia, because this again has a very different kind of predilection, by and large, to people in Hong Kong and then Southern East China, including some of the population in Singapore and Southern Asia like Philippines and Thailand. Some of the factors which are responsible for this is a virus again in this, and other factors which are environmental and genetic components is etiology, migrant from high to low risk country, retain incidence rates intermediate to the native of their host country and the country of origin, implicating the role of environmental and genetic factor, and possibly Epstein-Barr virus. So these are some of the factors which are bringing a change. So what we see East and Southeast Asia and Middle and Western Africa, where rates are low, in South, the highest liver cancer, this is coming to liver cancer. The liver cancer is highest in East and Southeast Asia and in Middle and Western Africa, whereas rates are low in Southern, Central and Western Asia. Now we see many of the factors which are responsible is the hepatitis B virus, which is responsible for a large number of cases. And then we also have HCV virus, hepatitis C virus, then alcohol-related cirrhosis and possibly non-alcoholic liver fatty disease, as should the obesity, are thought to account for the majority of liver cancers. Esophageal, again the variation we can see right from 1.4 to 22.3 because of, again, the dietary factors, which is high-risk areas stretching from northern Iran through Central Asian Republic to north-central China, often referred to as the esophageal cancer belt. And some of the factors which are there is poor nutritional status, low intake of fruits and vegetables, and drinking beverages at high temperature. In fact, we see in India, also in Kashmir, we see many cases of esophagus because they have a habit of taking tea at very high temperature, and which has been kept boiled for quite some time and with some decoctions into it, likely predisposing for esophageal cancer. Smoking and excessive alcohol, again, they have the major risk factors, and both combined together increase the incidence much more than when taken separately. But what happens most of the time, the people who are smoking and also consuming alcohol, generally they take it together, and that's why the incidence of risk factor for causation also increases dramatically. Then other factors which are there is overweight and obesity and chronic esophageal reflux. This is what is leading to adenocarcinoma. What we see, esophagus has three components. Upper and middle generally have squamous cell carcinoma, while lower third of esophagus has adenocarcinoma. We have different factors predisposing esophageal cancer in these three sites. The lower esophagus is more because of the reflux which is coming from below sometimes, or Barrett's esophagus or gastroesophageal reflux, which are more common for the causation of C esophagus in lower third, while the upper two-thirds because of smoking and alcohol and poor nutritional intake or high beverages habit. Bladder cancer again has a gross variation from southern Europe to middle Africa. This is one cancer which is more prevalent in Egypt because of infection, with chronic infection because of schistosomia. The highest incidence rates are found in countries of Europe, North America, and North Africa, which is Egypt, where it is very commonly seen. And mortality also is very high over there because of generally late presentation. So what we see in the bladder cancer, smoking and occupational exposure to paint and chemicals and industries are some of the factors. And chronic infection because of schistosoma hematobium is one of the factors for bladder cancer in Egypt in particular. What is happening is because of decline in the habits of tobacco and alcohol, and people becoming more aware to industrial occupation exposure, the bladder cancer incidence in developed countries now started declining. But in Egypt, where infection of schistosoma is coming down, but it is being neutralized because of increase in tobacco habits, and then tobacco-related bladder cancer incidence is rising. So there the benefit is not yet come. Non-Hodgkin lymphoma is again, the variation is there from 16.2 to 3.3 in different parts of the world, with the North America, Australia, New Zealand, Northern Europe and Western Europe, they're taking the lead. Except in Pakistan, we had shown that it was coming as third leading side. Otherwise, we'll see in most of the developed countries, the incidence of non-Hodgkin lymphoma is higher compared to the rest of the part of the world. In general, again, the incidence of Epstein-Barr virus, HIV virus, these were some of the factors which were considered to be responsible, but with AIDS-related NHL, now the incidence coming down because of AIDS incidence also fortunately is coming under control. But by and large, we can say the exact cause for this increase are not entirely clear, but could be related to altered immune function as part of the aging process. And that's why we see large number of cases in elderly age population in the developed countries. Kaposi cancer again was related to HIV infection, which was almost seen as an epidemic in the African countries when the HIV had just come up in 90s and early 2000. But now with the better control of HIV with drugs available, which are controlling the AIDS infection, the Kaposi incidence also is not seen that high as it used to be there. So what we can understand from this, the demographic variation in cancer due to difference in longevity and lifestyle people in different regions are there. Cancer is a part of aging process. Wear and tear of aging, natural probability of aberrant cellular division, and reduced capacity to control and repair the damage as part of the aging process gradually becomes lesser as an elderly population. And that's why generally we consider this as a disease of aging population, which is compounded by our own lifestyle habits and factors, which include tobacco, one of the biggest culprit, and then the dietary habits, so what kind of diet we are taking, then some viral infection, which includes human papillomavirus, hepatitis B, hepatitis C, Epstein-Barr, and HIV virus. Lack of physical activity, sedentary lifestyle, environmental factor, pollution, UV rays, alcohol, then red meat, then obesity. These are some of the factors which vary from one part of the globe to other part of the globe. That is the reason that we are seeing a very wide variation in cancer incidence in different parts of the world. We can to a large extent integrate yoga, Ayush for prevention of disease and promotion of health. So what we can do, once we are seeing that there are culprits which we are able to identify and which are responsible for higher incidence of cancer, we must also try to find a solution or some action against those. That means the first most important and most major killer is tobacco. We must quit tobacco and related products in all forms. They need to be stringent control at state level by banning the tobacco products. And we must also help people quit tobacco at individual level, where probably a lot of role will come from the speaker who's going to speak subsequent to me. It needs a very major behavior change on part of the person who is smoking, and they need a support at that time for quitting tobacco. So this is one which can be done. Then good healthy diet. Normal Indian vegetable diet, as mentioned, is one of the best because we do have very high residue in our diet. Physical activities, exercise, yoga, prevention against viral infection. Some of the vaccines which are available because of which cervical cancer and liver cancer are broadly coming under control. Control of environmental pollution, control of alcohol consumption, and we must explore potential role of other system medicine which are very much Indian, and we are still not giving much importance to that. So for prevention from cancer by integrating modern medicine with yoga and Ayush, with guidance from S-VYASA for adopting healthy lifestyle, we also are organizing a workshop on cancer awareness and prevention for SAARC Nation at New Delhi from 29th February to 3rd of March, where we are trying to bring all of the system of medicine also and trying to study their role in prevention. We are discussing the causes and then how we prevent, where the role of all this yoga and meditation, Ayurveda, Ayush will be discussed. Hence, let's all work together with all our skills and might to make cancer a history. Thank you very much.
Thank you very much, Dr. Grover. It was very important to be able to see these statistics, and it's clearly demonstrated from this talk that cancer is a lifestyle disease, and it's up to us whether we step forward and help with the control of cancer in our world. The next speaker is Dr. Santosh K. Chaturvedi. He's professor of psychiatry at what the acronym is called NIMHANS, the National Institute of Mental Health and Neurosciences here in Bangalore. He is a consultant psychiatrist and has been on the faculty at NIMHANS since 1982. He's been trained in psychosocial aspects of cancer and is very interested in communication skills training. He has over 100 publications, has edited a number of books, and is particularly interested in this field that we call psycho-oncology, understanding psychosocial aspects of cancer. And as you'll hear, this is a critically important area, and an emerging evidence is actually suggesting that factors like depression and anxiety can actually be prognostic indicators. So this is something that needs to be focused on and controlled. Join me in welcoming Dr. Chaturvedi.
Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. We've just seen the extent of problem of cancer globally and how it is related to the demographics and how rampant it can be. And Dr. Grover mentioned so clearly about lifestyle changes. Well, I'm going to talk about the mental health aspects of cancer. And these are mainly the impact of cancer, what is to be done when a person has cancer, and the lifestyle changes which could be important in cancer. And also, I would like to mention briefly something which gets ignored and neglected many times, which is staff stress in people having cancer. So, if there are students who are here, I would just like to know if you know what is the 5th vital sign and what is the 6th vital sign in health practice. Well, the 5th vital sign is pain, which is all patients who have cancer. So besides looking at their pulse, temperature, blood pressure, respiratory rate, one should always ask about pain. And we ask about pain in the form of either a visual analog or analog of 100 or a percentage or that. And the 6th vital sign is distress. Okay? So psychological distress in cancer patient is the 6th vital sign. By making it the vital sign, it means that we need to ask each and every cancer patient. Just like you take their temperature and blood pressure, you should also ask whether they are having psychological distress, because they are likely to have psychological distress. So this is an effort which has been made by the International Psycho-Oncology Society, and it is used globally. And I will now briefly talk about what is psychological distress in cancer, how do we measure it, how do we deal with it, what can be the factors which contribute to it. See, the term distress was chosen because it is much more acceptable. If you say that, well, I have a psychiatric problem, or I have a psychosocial problem, or I have an emotional problem. In a way, it indicates either a stigma, or it indicates that there is a weakness. Why are you, getting traumatized emotionally, or why are you having a psychological difficulty or problem because of it? But distress is something which, many people would be able to say how much distress overall it is causing. So it sounds quite normal. We all have distress. We have distress because of the heat, because of the rain, because of the prices, because of the traffic. We have distress for so many things. So distress is something which we relate to normally, and it can be done for cancer also. It can be defined and it can be measured by self-report as distress. So for definition, what is distress in cancer? It is a multifactorial, unpleasant emotional experience, of a psychological, social, and beyond that, something which is so much relevant in this environment of spiritual nature. So which interferes with the ability to cope effectively with cancer, its physical symptoms and treatments, and which extends from a continuum of normal feelings to sadness. And it can be because of, so this is how, we can have the distress continuum. There is a normal distress. If there is going to be some problem, we all will be distressed. But there can be very severe distress, so which is something which you can ask people, same way like we assess pain. If you have a visual analog, say, can you mark on this line how much distress is there? Or suppose you say 0 is no distress, 10 is the maximum distress, give it a number. Or 0 is no distress, 100 is maximum distress, tell us how much distress you are. Or how much percentage. So there are various, it actually takes just a single question to be able to get that. So when can distress occur in cancer? It can occur at the time of diagnosis. Actually, it can be there even before diagnosis if a person is having physical symptoms because of that, because of the disease. So at the time of diagnosis, when the diagnosis is being told, when there is curative treatment being given, whenever the treatment there is a recurrence or a relapse or a metastasis, that causes distress. When the disease advances, it causes distress. And then of course, when there is end of life care, there is distress. So the distress, if you want to call it in, usual terms, it might be like kashta. How much kashta are you having? So it's not pain. It is not sadness, kashta is distress. So it is related to physical symptoms. Sometimes it can be because of pain, fatigue, psychological symptoms, numerous fears which are there in cancer. It can be because of social concerns about the family or about the future. More importantly, things which cannot be measured and are very difficult to express are the spiritual concerns. We all know that people who, when they have any difficulty in life, so difficulty is not distress. But difficulty can lead to distress. So they have spiritual concerns. They seek religious interventions, philosophical interventions, or spiritual beliefs. They try to understand what is the meaning of all this. Why am I suffering? Why have I got this difficulty? And then the existential ones. What is the purpose of life? What is the purpose of this distress? What is the purpose of this disease? So the International Psycho-Oncology Society has something called as distress thermometer. Distress thermometer, as you can see, it's a 10 centimeter line which is vertical, just like a thermometer, and then you can ask a person to indicate where it is, and then you can look at, on the other hand side, what are the causes which can be, whether it is because of practical problems, because of family problems, emotional problems, spiritual, religious problems, or physical problems, which includes pain, sexual difficulties, skin problem, and various other problems that a person has. So you can assess distress in any person, and in a very simple way, and it might take not more than a minute. So who are the people who are at increased risk of distress? Like I said, distress is normal. It can be there in everyone. It can be as on a continuum. But those who have had previously substance use or psychiatric problem, had depression, who have cognitive impairment, where there are communication barriers, or if they have severe other diseases or social problems or family problems, those who do not have good social support, those who are living alone, the poor, those who don't have access to medical care, those who are young, and especially women, and those who are dependent, they are the ones who are likely to have more distress. There are periods of vulnerability, like for example, I said, if there is a suspicious symptom, if there is a lump, or if there is an infection not healing, or if there is a loss of weight which is unexplained. So one can find that, or when one is doing an assessment, or finding out the diagnosis, the issue of breaking bad news, when one is waiting for treatment, when there is a change in treatment, when there is an end of treatment, when there is a discharge. These are periods when a person is much more vulnerable. There are also stresses of survivorship. See, it's very difficult to live with cancer. You know, if a person has disease and it is cured, it's a challenge to also have the survivorship. So during treatment failure, when there is recurrence. So what is the impact of distress? The most important impact of distress is nobody asks about it. Nobody talks to them about it. Most oncologists would be interested in the physical part of the lesion. How big is the lump? How is the scar? What has happened? What is the bone scan show? What are the various things? What are the investigations? So people do not ask about the impact of distress on the person. So patients in distress actually visit their doctors more often, and they go to the emergency because they see a lump, another some feeling, and they think whether the cancer is coming back. They are worried about it. So they find it difficult to make decisions about what is to be done, and they become very dissatisfied with their physicians and medical care. In practice, what happens is the management of extremely distressed person adds to the time demands of a busy oncologist. They don't know how to deal with it. If a person who's very distressed becomes a little very uncooperative. So there is, they would not be listening to their advice. So they find it very difficult to deal with the person. So if we have a systematic screening, this may prove essential, and it will be very helpful in making an early evaluation and effective management. So there are psychosocial interventions which have been shown to be effective in reducing distress, and by reducing distress, we improve the overall quality of life. So it can be managed by family, religious figures, persons, traditional healers. Distress can be managed by a number of people. It doesn't have to be psychiatrists. It doesn't have to be a psychologist or a mental health professional. It should be their own doctors also. So the health resources are poor, and like I said, distress is very low on priority. Most hospitals and doctors follow the policy, don't ask, don't tell. So management of distress. Once you detect distress, talk about distress. That itself is therapeutic. People feel better when they talk about their distress. It's a ventilation. So it should be detected, recognized, monitored, documented, and treated properly. You should see what are the factors causing the distress. So all patients should be screened for distress at the initial visit, and it will tell you what is the level of distress, and then we can do the management. So the goal of distress management is that no patient with distress should go unrecognized or untreated. So second thing I would like to talk is about depression in cancer. So we know that it is an emotional reaction, and emotional reactions are bound to happen whenever there is a severe stress, whenever there is a severe diagnosis, and it happens with cancer because it is life-threatening, the prognosis is uncertain, there are fears of death and dying, there are a lot of very, very troubling symptoms like pain, edema, nausea, and then there are unwanted side effects of surgery, chemotherapy, as well as radiation therapy, and of course, much larger is the stigma. So in our studies, we have found what are the common coping mechanisms which you will see. And we worked with, very closely with the Kidwai Cancer Hospital for more than a decade. And we found these as to be the common coping mechanisms that we found. These are different from the Western literature. First was denial. They thought that there is nothing. And second was resort to religion. Ye to Bhagwan ki deen hai. Ye to Allah ki marzi hai. So they just resort to religion, or they put it on the fate, karma, and lastly, like for all other problems in life, helplessness. You know, there's nothing that we can do about it. And we found that people who had these coping mechanisms, they found that the resolution of their stress was less than half of them, and poor resolution leads to distress and depression. Internationally, what we know is that there are these 5 types of coping mechanisms. Fighting spirit, which is very good. Avoidance or denial, which is also very good. Fatalism, that you put it on fate, that we don't know whether it is good or bad. People having hopelessness and helplessness, that is a bad emotional reaction. Those who are anxious and preoccupied, we don't know whether it is a good or bad. So the common psychiatric disorders vary from 20 to 60%. There can be adjustment disorders, which is the commonest, depression, sleep disorders, anticipatory nausea, vomiting, post-traumatic stress disorder, body image dysfunctions, or problems like, for example, post-mastectomy or with colostomy, and sexual dysfunction. What we find here in our country is, and in Bangalore is, that the commonest is adjustment disorder, almost 44%, and half the patients are likely to have psychiatric disorder. Globally, we find that major depression again is from 3 to 38%, and depressive spectrum disorders is even more. Some regions have a much higher prevalence, like for example, brain. If there's a brain tumor, the likelihood is from 40 to 90%. Pancreas is up to 50%. It is one of the most severe of depressions that we see. There's some people try to make a difference between depression and demoralization. Demoralization is in a person who feels he does not know what he can do about it, feels totally helpless, totally incompetent. There is a spiritual part of expression which is indicated in that. So depression, again, like distress, is under-recognized. The same way, because we find that not many people in their undergraduate or postgraduate are taught about how to recognize depression. So there is a professional reluctance, people are not being trained, there is emotional self-protection. Suppose I ask about depression, suppose the patient is depressed, suppose the patient starts crying, what will I do? We don't know what to do with that. Or they attribute the physical symptom to the physical illness. Or they assume that, of course, he is bound to be depressed. So they think that it is very natural. This is another thing that we find which is very interesting, that half the people who go to a cancer hospital do not believe that they have cancer. So is it because of denial? Is it because of, avoidance? They think that it is just one of those things. And people who have denial, who are not aware, actually do not have as much of psychological problems as they would be there. So how do we screen? We can use common scales are there, the hospital anxiety depression scale, which is a 14-item scale, and one can easily use that. And why we need to do it is because depression affects the survival in cancer patients. Not only it causes depression, it also causes changes in the underlying disease. There are different ways by which depression affects the adherence to cancer treatment. Those who have depressed are unable to integrate cancer diagnosis and treatment information. There is a reduced motivation. They avoid health-promoting behaviors. There is a social isolation. They reduce the use of community resources, and they do not tolerate side effects. So principles of management, sensitive communication is very important. We regularly hold workshops on communication skills, on how to talk to cancer patients, how to talk to their relatives, how to talk about the diagnosis, how to break bad news, how to provide information, how to handle their difficult questions. How long do I have to live? Will I suffer? How will I die? What will happen to me after death? So there are many difficult questions which are roaming around in their mind, which nobody is there to listen to them or to talk to them. So clarifying their concerns, encouraging confiding tie. Confiding tie has been found to be a good prognostic factor for the disease of the person. If a person has a good confiding tie, they have a better prognosis. If we involve the patients in decision making, the outcome is better. Setting realistic goals, the outcome is better. Use of psychotropic medications for a short period of time and antidepressants is going to be very helpful. Like I said, effective communication skills, handling difficult questions, handling anger in the patients. The most important question is, why me? And so many other people smoke, but they don't get cancer. Why me? So many people don't smoke. They don't, but I don't smoke. So why me? So why me is a very important question which is troubling the persons, and it causes a lot of distress. And there are spirituality issues. Usually by professionals, they have a lot of blocking behaviors which comes in the way of communication skills. So very briefly, how do we do it? When a question is asked, acknowledge that this question is there. Ask the person what he already knows. Give small bits of information in simple language. Check whether they've understood it. Check their feelings and go to the next question. So how do we prevent or reduce depression? By allowing the person to make a choice. By use of rehabilitation methods, prosthetic techniques, by care of colostomy. If a person has had mastectomy, provide them prosthesis for that. Reduce myths about radiation treatment and chemotherapy. Reduce the toxicity of chemotherapy. Reduce financial burden with support and through pain relief and symptom control. Very briefly about staff stress. Nobody asks the doctors or the nurses how they are feeling. Seeing so much of morbidity, so much of mortality. So that is one of the reasons why they have problems of communication. They have difficulty in taking decisions, breaking bad news, work overload, repeated confrontation with difficult and delicate situations, unrealistic objectives, admission of dying patients. These are things which cause much more stress. So to summarize, we should consider psychological distress as a sixth vital sign and assess in everyone. We should also assess for depression and involve other psychosocial support like NGOs, volunteers, survivors. We need to train trainers as well as doctors and nurses in communication skills. Keep up supportive services home-based as possible and not hospital-based. Provide locally relevant researches and measures, and need for services suitable for local needs as what is required. So with these few words, thank you very much, ladies and gentlemen.
Thank you very much. This was a very important talk, and to let the audience realize how important this area of distress, mental health, and this field of psycho-oncology truly is. Distress being the sixth vital sign is still in the not being embraced by the conventional medical community to the degree that it should be. In the United States, by 2017, distress is mandated as something that needs to be screened on a regular basis, but there's still confusion as to what do we do about it. And of course, mind-body practices coming from the Indian tradition of yoga and many other Eastern-based practices will be one option for people to help manage their distress. So thank you for bringing this very important topic forward. Our last speaker at this session is Dr. Gopinath. He comes to us from the Healthcare Global Enterprises Limited, which is an organization in Bangalore. He obtained his MBBS from University of Mysore and MS from the GS Medical College in Mumbai back in 1978. He's an oncologist and has been involved in...
You have 20 minutes.
Pardon me? Has been involved in oncology since the late 1970s and was part of the Kidwai Memorial Institute of Oncology through 1991. He has numerous awards that I don't have time to share with you because I want him to be able to share what he's been doing more recently, which is been actively involved in research on yoga for breast cancer. So join me in welcoming Dr. Gopinath.
Thank you, Mr. Chairman, for your kind words. Let me thank organizers and Dr. Guruji and Dr. Nagaratna who invited me here to speak. I actually start from what my two of the previous speakers has mentioned it earlier. Dr. Grover, one of my very good old friends for more than 2 to 3 decades, has presented the overall demographic data. And later Dr. Chaturvedi has given you an overall on how the cancer is looked at by the patient and the treating physician. And many times the sixth vital sign, distress, is really ignored by the treating physicians who are mainly involved in the management of cancer. So there is a little change in the title which Chairman has mentioned it. I am trying to take you through and giving a classical example, choosing one organ, what has been told to my both the speakers, Dr. Grover and Dr. Chaturvedi. I called it a life after breast cancer and beyond. Because the most important thing is you must know what is the... I have chosen the breast cancer as one of the important entity. You are all in the city of Bangalore. Bangalore is well known not only as a science city, as a Silicon Valley, and it's the city of breast cancer too. You must have seen from the demographic data shown by Dr. Grover that there is an increasing trend of breast cancer in this part of the country. So I divided my talk into 3 parts. What is the current treatment scenario in breast cancer? And then what is the life of these patients after the breast cancer treatment when they undergo various treatment modalities? You are all aware that from the demographic data and recently publication from Lancet that India is facing growing breast cancer epidemic. If you look at the breast cancer scenario of the cancer registries in India, we have got a population-based cancer registries and hospital cancer registries. that only reflects the tip of an iceberg of incidence. And we all know that this breast cancer has overtaken the cervical cancer, and today breast cancer is becoming #1 in all the metropolitan registries, but in some of the hospital-based cancer registry and the rural population registries, cervical cancer is still the #1 in the country. And as I told you, the Bangalore is the breast cancer capital. Not that I am proud of it, but this is the incidence. Maybe due to various reasons, we have to look into the thing, because Bangalore has got a large migrant population, lifestyle changes could be one of these things where we are seeing and a very good population-based cancer registry of ICMR, which really documents the incidence of cancer in the city of Bangalore, and various risk factors Dr. Dover already highlighted. I don't go. If you look at the data, 1982 to 1989, the first population-based cancer registry published, we used to see 11 to 13 per population. Today, the recent data says 36 to 40 per population. And other observational changes, what we have noticed is the breast cancer is seen 10 years younger than the Western population. Triple negative breast cancer, what we mean by ER, PR, HER2 receptors, are more common in Indian women, especially in a premenopausal group. These are the various epidemiological data which is published and available to us, so that every treating cancer physician should be aware of this. And today we see that 145 new cases are diagnosed every year, 17 to 40 per 1 lakh, 60 to 70% of are those locally advanced breast cancer, and 5-year survival rate is nearly 42 to 46%. This is because of the population-based cancer registry publications which has been published by ICMR. Our philosophy in management of breast cancer today is detect them early, cure, conserve, cosmesis, and comfort. All these things are possible because the emerging concept of multidisciplinarity in development, indicating that it is not the one person who is treating the cancer. We should develop a team. Then the success of because of the concept of multidisciplinary team, we are seeing the success rate and cure rates in breast cancer management across the globe. So let us look at, we all know that already Chaturvedi has told patient presents to us with the breast lump. Breast cancer is usually presents with a lump in the breast. We make a clinical examination. We stage the disease. In an early stage, surgery is one of the methods of treating the breast cancer. From last century and on, we have seen the changing trend in management of surgery. You all aware that 1894, William Halsted performed the first mastectomy. Till 1950, there was no challenge for him. Bigger and biggest of the operation was the concept in management of breast cancer. Later, the challenges came from two, Varanasi and Bernard Fisher, which a lot of people are aware of that. He was the first leader who said cancer is a systemic disease. There is no need to do the bigger and biggest of the operation. You treat them with a systemic therapy, do the lumpectomy. After all these things, today we are in the era that there is a need for what is called as combined modalities of treatment, usefulness of neoadjuvant therapy and adjuvant therapy, and we can give the breast reconstruction and oncoplastic surgery. This is what we change in the management of breast cancer. Starting from the days of Halsted, Dr. Chaturvedi has told that mastectomy was one of the lovely operations which we all used to do it. Today we have boiled down to breast conservative surgery and oncoplastica, where the body image disturbances which are happening in these patients can got rid of by doing a breast conservative surgery. That is where distress in a woman can be taken care of, and that is how one of the treatment of the distress is body image disturbances has to be answered in management of breast cancer. How all these concepts are evolved, we are all aware that NSABP B4 protocol, B6 protocol, first published in 77, 30 years later, 2002, same data indicating that everybody will have any evidence to say that lumpectomy with axillary dissection, lumpectomy with sentinel node localization is one of the modalities everybody can practice any part of the globe. These are the two important articles, and the same surgical options you are all aware of, that tech and technological advancement has been made. Today, even mammography is available in every part of this country to make an early diagnosis. So I will be trying to go through the surgical approach to diagnostic, surgical management of early breast cancer and reconstructive surgery. And FNAC used to be one of the useful diagnostic tools. From then onward, today we have moved into TrueCut, especially the image-guided TrueCut biopsies, where you localize the disease and have a good tissue diagnosis. By making a tissue diagnosis, you can also study the prognostic parameters and sit and talk to the patient, communicate with the patient that this is the stage of the disease, these are your parameters, this is the method of treatment you have to undergo: breast conservative surgery with reconstruction, breast conservative surgery without reconstruction. All these parameters can be done utilizing the diagnostic biopsy techniques. And as is our pathology, so is our practice. William Osler said many years ago, still it holds good. Once you get a good tissue diagnosis by using a TrueCut biopsy, today we are all in the era of what is called as molecular profiling. You can do the molecular profiling, especially with special reference to BRCA1 and 2, where hereditary cancer documentation is increasing, where treatment has to be planned. And you are also aware that I was telling you the triple negative patients will have a high incidence of BRCA1. We can answer the families also. This is where the molecular profiling can be done and patients can be managed. Surgical options, I already highlighted to you the significance of breast conservative surgery. What is the meaning of breast conservative surgery? It is the excision of the primary tumor and axillary dissection. From axillary dissection, we moved on to the concept called as sentinel node localization, because axillary dissection, level 1, 2, 3 clearance used to cause morbidity of lymphedema. Today we got rid of it in some of the early cases, non-palpable lymph nodes in the axilla. The lymph node not detected on ultrasound imaging, we can offer the patient the sentinel node technique, which I am going to tell it to you. In a broad nutshell, breast conservative surgery means excision of the primary, managing the lymph nodes, and along with that, all these breast conservative surgeries has to undergo adjuvant radiation. Depending upon the complete histopathological picture, you can plan them chemotherapy and hormone therapy. And when to do BCT, non-palpable lump detected on mammography or clinically detected T1, T2, N0, N1, they are the indication. When not to do BCT is also very important, especially the young postgraduates sitting in the audience should be aware of, otherwise mastectomy is still a gold standard. Whenever we talk about the breast conservative surgery, we always talk about the margin. Experts always debate and discuss and create controversy. How much is the margin? In an Indian context, when you are seeing the palpable tumors, minimum 1 centimeter of clear margin is very much mandatory. This should be the outcome results of BCS, cosmesis, cure, comfort to the patient, where a patient should not have any problem of body image disturbances. Management of axilla, I told you earlier years we are doing routine axillary dissections. Today we moved into the sentinel node biopsy concept. If sentinel node is negative, no need to do the axilla, and we can always reduce the morbidity of lymphedema, which is one of the well-known dreaded complications of axilla when the patients are followed up for a long time. What do you mean by sentinel node biopsy technique? We understood the anatomy of the disease. We understood the biology of the disease. We knew that the cancer spreads many times in a very conventional fashion from the local disease to the nodes, and that is why there is a new concept emerged, what is called a sentinel node. When it came, everybody thought sentinel node is a one node. It is not so. We use a dye or an isotope, and nowadays we use routinely the radioisotopes, inject into the nipple areolar complex, use the probe, detect the values, send it for frozen section, and if the frozen section is negative, there is no need to do. If the frozen section is positive, you can do the level depending upon the size of the tumor, site of the tumor, the limited axillary 1 and 2 clearances. And in the sentinel node, we have advanced technology like what is called a 3D radio-guided surgeries. We can inject it, use this machine. We have recently acquired it and have it in nearly 55 cases we have done so far, so that one of the important complications of lymphedema. And don't carry on the message that only breast conservation is the answer. Many parts of this country, we do not have a complete facilities. mastectomy is still a gold standard operation, especially for the tumors which I am showing it to you. If you do not have a complete team to develop or multidisciplinary team, still as a treating surgeon, you can do a good mastectomy with axillary clearance and plan your treatment. That is how the treatment. And in some of the selected cases, we can do skin sparing mastectomies and using a breast implant with silicone prosthesis. In short, management of breast cancer, a clinical examination, stage the disease, plan the surgery. After studying the complete histological examination, subject them to adjuvant chemotherapy, target therapy, radiation, and hormone therapy. The important questions come, patients undergoes all this treatment. Always there will be something boiling in their mind. How will I? Moment we tell them come once in 3 months for treatment, at the end of 2.5 months it started coming, what my doctor is going to tell. Whether I got my cancer come back, I have got pain here, I have got lump here. As Dr. Chaturvedi has clearly mentioned it, what we call in our oncological language, the Kubler-Ross effect still continue to present in them. How is the life after breast cancer treatment is a very important thing. Even many of the oncologists doesn't look into the thing. Though we are in the era of personalized medicine, biomarkers are available for prediction and prognostication. This important aspect of distress, which is the vital sign, is very important. And that one should answer these things. We are all aware that we are awash in the sea of information. When it comes to the management of the patient, we are always lagging behind in understanding what patients expects from us. Life beyond breast cancer, professional perspectives, patient perspective, post-cancer parenthood. Many times we don't discuss with our patient. After interacting and the demand from the patient, we started looking at all these things. This is what Dr. Chaturvedi has mentioned it, that distress is an important aspect of it. Today, every oncological institute has got a psycho-oncologist who counsel them that treatment doesn't end. Even when you come for follow-up, we should look beyond it and we should address some of these problems. Changing people's perceptions of cancer has been already told. Stress is an important aspect of breast cancer. When you sit and ask the questions to the patients, they always say that there are some lifetime events. After this, I noticed either my husband died of myocardial infarction, I noticed this lump, or my daughter or a son did not get into the professional course. I have this, my daughter is not married for so many years. These are the common questions when we were discussing with the patient that came with it, and we thought that there is something into it. That we looked at the psychoneuroimmunological breast cancer patient and concluded at that time that most important thing is we must discuss some of these problems with the patient. And Kubler-Ross effect has been already very well highlighted by the distressing vital sign number 6. Every patient feels, why did I get it? I am so nice person. I do puja every day. I have not harmed anybody. This is what is called as Dabda effect, coping concern. Chaturvedi has already mentioned how to get out of this. And we looked at, and we did a study of our own group, nearly examining more than 3,000 breast cancer patients across the country. And we felt that every cancer patient needs a psychological counseling. That is the conclusion we did it. We also recommended that there is a need for psycho-oncologists in every cancer institution set up, and every patient has to go through that. Why these things happen? Today we know that stress is an important entity. Stress is because of the hypothalamo-pituitary axis. We all know that pituitary and hypothalamus are the bandmaster of neuroorchestra, which releases lot of hormones. That is how we looked into it. And nearly 10 to 12 years ago, when I met Dr. Nagaratna, she was my teacher in the medical school who taught me the basics of clinical medicine. She said, Gopinath, we are working on diabetes and hypertension. Why can't we look at some of the cancers? That is how we came across and started the concept of utilizing yoga, what I call it as spiritual hypothalamo-pituitary axis in management of breast cancer. Chronic stress, you are all aware of it. And there's a nice already which has been told, and there are studies which have been shown in the mouse models how stress can induce cancer, especially the ovarian carcinoma model. These are all the literature available to us. The need of the hour is to resolve the psycho-immune balance for cancer patients, incorporating the psychological intervention as an integral part of cancer patient management. There is a need for CAM, integrative oncology, and they should be the member of multidisciplinary team member along with surgeon, radiation oncologist, medical oncologist, pathologist, and everybody. This is what today we are in the era. We have developed the team with all these things. These are some of the famous statements. Disease, body and mind is an important entity. And we did some of the studies on psychoneuroimmunological axis. We utilized the spiritual hypothalamo-pituitary axis. We had come to a conclusion, yoga as an adjunct to conventional cancer treatment. Our aim at that time was, can yoga reduce the psychological morbidity? Can yoga improve the quality of life? Can yoga bring about favorable immune modulation in breast cancer patients? This is the yoga model. I don't want to go into the details, which you are all aware of, how some of the relaxation exercises can be performed utilizing yoga. And this is the research team by myself from the HCG, BIO, and Guruji, Dr. Nagendra, and Dr. Raghavendra, who did his dissertation and obtained his PhD from the same Vyasa University. And these are some of our publications in relation to yoga and breast cancer. And what are the conclusions from all those studies is, following surgery, there are some various psychological outcomes, and especially the outcomes were more when we did a mastectomy rather than breast conservative surgery. We compared the post-operative outcomes. We also looked at the immune outcome, indicating that there was a reduced decrease in the NK cell activity and serum immunoglobulin levels. And during radiotherapy, these are some of our observations. And similar things to the chemotherapy. Chemotherapy is always caused more distress than the surgery and radiation as a modality of treatment. We did this study before surgery, after surgery, before radiotherapy, before chemotherapy, and follow it up, indicating the distress was more when the patient is on chemotherapy. And this is where it made us to think that we should have an integrative oncology, have a yoga department in our hospital where patients will undergo all these modalities of treatment. The yoga modules are taught by the yoga instructors, and we need more number of yoga instructors all over the country when we see the number of cancer burden in this part of the country. And today the emerging concept, as I told you, the patient undergoes various types of treatment, and if you sit and listen to the patient, the caregivers and the family members will be keep on talking about it. Sir, my mother was so quiet lady. After this treatment and everything, for everything she gets angry, she shouts at us. Why she is behaving, I don't know. Whether she is always scared that cancer can come back. As Dr. Chaturvedi has already told, today we are in the new environment, what is called as chemo brain. I have already talked to you the significance of the pituitary gland, which has caused a lot of hormonal changes, and especially in relation to chemoradiation, chemotherapy, and hormone therapy. We are trying to understand the pathophysiology of chemo brain, how to utilize this integrative medicine. Chemotherapy effect on chemo brain, as I told you, our observation is the behavior of the patient, and now we are trying to look at some of these patients. We never understood 2 to 3 years ago why patients are behaving, why patients are angry, patients were not happy, patients were all irritable. Today we understood the concept of chemo brain, and that is where the role of integrative oncology comes into picture. And this is to go more into the depth of what the stress and the various aspects of chemo brain microenvironment. I don't want to confuse you. As a practicing clinician, we know that mind, body is more important. Disease, body and mind. Utilize yoga as one of the important modalities of treatment, which is very cost effective. Patient need not have to pay the huge amount of money. Along with yoga, you plan your methodology of understanding the neurophysiology, chemo brain, and today the chemo brain and the various parameters can be assessed. Use that as an investigative protocol. Offer your patients a good quality of life. This has been highlighted by the various publications, even in a journals like Time. And today some of these patients, when they are doing well, when they are very young, they are all triple negative. They did not have a child. When the patient has a cancer, they came back and started asking us, can I have a baby? We cannot say that you have got a cancer, you can't do it. Today there is a changing world. We understood that after all this concept of life beyond, utilizing yoga, keep their body and mind cool, offer them what they wanted it. Today the childbearing age, we are seeing the cancers. We preserve their oocyte donation, In men, we preserve their sperm. Whenever it is needed, we can always utilize it and ask the patients to have their babies. This gives them a more comfort than any other modalities of treatment we offer them. This is just to show you how we plan our infertility program, because Bangalore has got a few infertility people who have joined with us in our team and offering these services to us. And this is the rates of post-cancer parenthood. And another important thing, the common question asked by all the women with breast cancer is, will my daughter develop the breast cancer? And today, 10 years ago, we were in a very difficult situation as an oncologist. We were in distress to answer those questions because the facilities were not available. Today, we can do the various genetic profiling. We can do the BRCA1 and 2 and tell the patient what is the situation of their families. What the counseling is once again very important, as Dr. Chaturvedi has highlighted. Here is a place where not only the genetic counselor, a good clinical oncologist should spend time, involve the psycho-oncologists and subject them to what is called as risk-reducing surgeries, which you are all aware of the famous Angelina Jolie effect. When the paper spread the news, we are having a more tough time in answering to our patient. Today, with the facilities available, we can comfortably do the prophylactic mastectomy with reconstruction and risk-reducing surgeries like prophylactic oophorectomy. Ladies and gentlemen, the treatment of cancer is not only by the surgeon or a radiation oncologist. Today, we should look beyond the treatment of us. Today, we have seen with all these things, they are not the cancer survivors. I call them a cancer conquerors. The basic philosophy of a treating physician is convert our patient, not only the cancer survivors, cancer conquerors. We are going to have two important conferences in this country, one in Delhi, Asian Clinical Oncology, another in Bangalore. I welcome all of you this meeting. Present your work there. We will have a good interaction and also to develop the concept of integrative oncology in management of breast cancer. Thank you, ladies and gentlemen, for your patient hearing. Thank you.
Thank you for that wonderful talk and for all three of our speakers for their vision in coming from the very conventional world, all of them having conventional MDs and being willing to step forward to this field of integrative medicine, and here in particular today on this panel, integrative oncology. So thank you all three for this wonderful talk. I'm not going to share any of my own personal remarks. I'm giving an opening talk tomorrow, and we'll be speaking for an hour expounding on this topic of integrative oncology, and in particular some of the work we've been doing at MD Anderson in the area of yoga and comprehensive lifestyle change. Our next session, I believe, is a coffee break, and then there will be a panel in a different location that our organizers will share some of those details. So thank you all for attending, and we will see you at the next session.
Thank you, dignitaries. Now I would ask Dr. Lorenzo Cohen to felicitate all the three speakers. First, Dr. Lorenz, please felicitate Dr. Rajesh K. Grover. Felicitation to Dr. S.K. Chaturvedi. Felicitation to Dr. Professor K.S. Gopinath. Now, before the tea break, we have a short presentation from Ramachandra Kamath. He is a mechanical engineer by training. He has 10 years working experience in clinical applications for clinical trials. Founder President of vSoft Infoware, Princeton, New Jersey. He has an end-to-end e-clinical solutions. Today he is speaking on e-clinic. I welcome Ramchandra Kamath.